Okay. Phew. Hopefully that's live on YouTube now. Looks like we're up there. My goodness gracious. So if you can see me, if you can hear my voice, it says I'm live on YouTube. It says I'm streaming on YouTube, Facebook, and the X. So hopefully that's coming in. Okay, here we are. Cool. Wow. So Restream not crushing it these days. Usually does a nice job. We got a little setup here. You can see I'm not as crispy clear because we're in 720p because we got a guest today. Fancy day. We're welcoming back a favorite of the show. And so I'll just give a second. It looks like, oh, here we are, finally. Crushed it. All right, Cameron's here, Michelle's here. Oh, look at that. Doryu is here. Nomad over normal. Hello, hello. Greg, hi. Dr. Nick, good to see you. Bill, really appreciate you guys popping in. So, we got a topic today. We're going to talk about hypocapnia. Some of you know what that is. Some of you don't. That's okay. We're going to talk about it. We're going to talk about it in a way where I'm just going to let you know this is how we talk about it with physicians in class. Hello, my love. Is understandable and usable at home. It's going to be beautiful. I got a little peeker through the window. She had school pictures today, so she's still wearing her dress, looking great. And we're going to get to it. But wait, let me say goodnight real quick, and then we'll get the action going. Yes, this was good.
Just the brand that makes ice cream shorts. Yeah, it's so cool.
Right in a minute. All right, bud. Okay, that was the first guest of the night. Hope you guys enjoyed it. Megan Bradford, good to see you. Eileen, good. Hopefully you got the bodyguard there. I don't know if you noticed. Got my locks shaved down. Got a whole bunch taken off. I know it's not obvious to the naked eye, but we did get a haircut to celebrate the bodyguard's cut. So thank you for that. Tracy's here. Amy's here. Nicholas, good to see you. Baby B. I'm going to call you that, but I love that you're here, Cheryl. All right. Corey's here. Christy Lee. What a squad. We're going to do it tonight. All right. So I have to tell you, so we've been keeping her in the dark over here, but we got Dr. Kipros here. Long time since we've had you. Good to have you back on this program.
Hello.
All right. So Dr. Kipros, we talked last week about doing things where we're just giving people some more stories, a little more evidence of what we're doing. And we had a little highlight we wanted to do this week. Dr. Kipros is going to share. Should I let you take it away?
Yeah, I'm excited. There was a lot of suspense there. I wasn't sure if we were gonna.
We like to keep it interesting. Restream does that. They don't even charge us extra for that. They'll just be like, everything's going to run smooth right as you go live. Just kidding. We're not going to stream tonight. And then that's how they like to play.
I like it.
All right.
Well, I kind of
So what do you got for us?
Jump on and talk a little bit about some exciting stuff that we've seen come through the clinic recently. So I want to talk about a patient we had in a little while ago. And then one of the cool things, is there a lot of feedback?
I don't hear feedback. Do you hear feedback?
Okay.
Let me, I can mute myself.
It might be
Here
on
I go,
my
ready to say.
end. So something we like to do when patients come into the clinic is follow up with them pretty consistently after they leave. So I want to chat about kind of what one of our recent patients looked like when she came into the clinic, and then a really cool update that we've had this week. So This patient was with us about a month ago, and she came in, chief complaints of a lot of difficulty being upright. So she was tachycardic when she was upright, dizzy, lightheaded, motion sensitivity, nauseous, difficulty breathing. It ended up putting her, when she came to us, about 20 minutes of upright tolerant time per day. So she was basically laying down for the rest of the day. As you can imagine, or as anyone can imagine, this makes it very difficult to do anything around the house. She was basically bedbound. She wasn't able to do her job. Going in the car with regards to her symptoms was a big no-no. Exercise intolerance, fatigue, a lot of heat intolerance. She was unable to be outside for long periods of time or even stand up in the shower. So she came with us. She was an extremely hard worker. So she was with us for about a week. When we started with her, we put her through the whole examinations, but some of the key findings that we found was on her tilt table exam, she was hypocapnic, which we'll get into in a little bit. And then she was hypoperfused. So when she went upright, her end-tidal carbon dioxide levels dropped lower than we want them to see. And the amount of blood that she was able to put into her head was lower than we would want to be able to see. So she worked extremely hard with us for about a week. She knew she was on a shorter time frame when she was in the clinic. And then she has now been working at home on a home exercise program for about a month. We just got a 1-month follow-up from her, and she told us that she has been working diligently on the exercises that she's been given, which is no surprise based on her attitude when she was in the clinic. And she told us that she has been able to get rid of her shower chair, which she had been having to use in order to be in the shower. She has more upright time during the day. She's actually been able to tolerate car rides. She went out and actually walked through a parking lot, went into a store, ordered something, and got back to her car, which was crazy exciting. And she's also been able to go out to the pool and hang out outside for about an hour at a time. So we got this email from her, and she was kind of downplaying it, and that I think I'm heading in the right direction. And we were all hooting and hollering in the clinic. So wanted to kind of say how exciting that was for us on our end, and just to give big props to her for all the hard work she's been doing.
For sure. We wanted to give her flowers, so hopefully she feels really good about that. But our favorite part about it is it's really easy to come on and show a before and after, like the weight loss studies, and be like, look at how amazing this is. But what I really like is being able to highlight people's hard work. So this is just pure commitment and motivation, and just being able to do the work and see that tick forward, which I think is super cool. And I think other people here have experienced that, where every moment isn't rosy. There's the white knuckling it through sometimes, but it's really fun to watch and see people take their health into their own hands, which is super stinking cool, and be able to dig themselves out. So we just wanted to highlight that and highlight some hard work. And we got that little note about a haircut, same ideas. So I just love that. And you gave us a good segue into our topic for the evening, which we're going to dive a little bit into understanding the relationship of breathing, but CO2 levels, really, in terms of how we think about blood flow in our brain, how we think about blood flow pretty much everywhere. And I think that's kind of the key part that we're missing. I see Dennis, what's fun about this, Dr. Kipros, is in this view, I get to do this thing right here, where I show the comment and I go, and he said they're doing clinical trials at University of Calgary to see if administering CO2 alleviates POTS symptoms. And they are doing that. They've been doing that for a little while. And they've also, so this has been piloted before, and then also using isocapnic devices on a tilt test to be able to understand this. And Julian Stewart has really paved the way here. Excited to see what they come up with in Calgary. Administering it artificially is a nice way to think about that as well. But should we get into it?
Let's do it.
All right. So I'm gonna actually, you know what? Since we're both here, I'm not gonna pull it out. I'm just gonna kind of talk off the cuff here. So let's talk about what hypocapnia is, why it matters first. Cool.
Cool.
So, hypocapnia, or as our friend Amber pointed out for us today, again reminded us, hypocarbia if you live in other continents on the world, right? But we say hypocapnia here. Why? Don't know. That's what they write in papers, and that's what I've been reading for a long time. So that's what we say. But it is hypo is too little. Capnic is in reference to the amount of CO2 in the bloodstream. So there are a couple ways to look at it. You can look at it as what they call the partial pressure of CO2 that's dissolved in the blood. So you can imagine like, um, I don't know, if you got like sparkling water, let's say, and in that sparkling water, you have some dissolved fizzies, some carbon dioxide in the water, and that's what makes it fizzy, which is kind of cool. And so you can think about it like that. So that is dissolved in the water. We have CO2 that's dissolved in our bloodstream, and that can be measured in a blood draw. The downside to that is like it's really hard to get a continuous monitor on a blood draw. It's inconvenient, right? So the way that we can supplement that is we can use a capnograph or a capnogram, and we can sample it. So we can get a sample of the air that you're breathing out, and we can actually start to measure the carbon dioxide that you're breathing out. And that becomes a proxy to a degree of the CO2 that's in your body. Why does any of this matter? Well, the reason that we like to measure the CO2 levels is because CO2 tells a story. It tells the amount of CO2 is a constant signal. The amount of CO2 in your blood is a constant signal to your brain, to your peripheral blood vessels about how much new oxygen we need to be bringing in. So if there's a lot of CO2 coming out of a cell, that means the metabolism's high. It can be like that. It's working. And then we want to pull new fresh blood in. So that allows us to get a little reflexive mechanism so that we can locally dilate that blood flow or dilate that blood vessel, excuse me, and then be able to get more perfusion into the capillaries in that area. And our brain is super, super sensitive to this, which is why it's important, because when we measure cerebral blood flow, we have to correlate it to what's going on with those CO2 levels. Makes sense? Stop me right there. Dr. Kipros, what do you think? Anything you want to add? All right, cool. So if we know that, we can know just really simply that when CO2 levels go up, we get more metabolism. That's going to kind of cause more blood flow into that area. And then if we have low levels of CO2, this is hypocapnia. Cool. Then we're going to actually see we're going to reduce the amount of blood flow to that area. So it's pretty important. And in a mechanism where these are actually reflexes that are controlled by the blood vessels themselves, anything that harms the integrity of the blood vessel or affects its ability to have normal reflexes, particularly in the endothelium, we can get problems. We can get problems with the coordination of blood flow in the brain. So when it would usually say, we're working hard over here, can we please have more blood? Then that may not actually be represented in what happens, and then we get problems from there. Cool. So one of the things that becomes a question is usually when you look at research studies, they say, hey, the CO2 levels in the bloodstream are going to be correlated to how much you are breathing, which makes a ton of sense. And that's usually the way it goes, right? So if we've talked about this in the past. Some of you will remember, some of you won't, some of you never heard it before. But if someone breathes too fast, this is a form of hyperventilation. So it's too much breathing, right? You think about like a TV sitcom, people breathing too fast, they put the bag on their head, away you go. So if I breathe fast, this is called tachypnea. If we breathe too big, like too big, deep, shallow breath, or deep and shallow, too big of breaths, like like this kind of breathing, you end up blowing a lot more carbon dioxide out, and it takes your body a little bit of time to replenish that. And if it can't replenish it very well, then we get hypocapnia, so the CO2 levels go down. And then we'll see some pretty like consistent things start to happen as that goes. People will become more anxious. They will start to feel like they're getting a tingling sensation in their body. They may start to even get some cramping in their hands or in their feet. And usually it kind of looks like that. And they might notice that they're getting some numbness around their face or a little tingling around their face, or they might even start to notice changes in their vision. So, this is kind of why there is, well, not why, but this is a reason why when you see people that go to the ER and we're getting these types of symptoms that may not be related to heavy breathing. It may be related to something else, but it looks like that. And people, especially in the ER, are used to dealing with people that are in a moment trying to get out of it and that may experience something like a panic attack, something that looks like hypocapnia. So a lot of times they're kind of just tossed into that bucket off the start. And so the conversation we're going to have is around how do we think about this, especially in terms of tilt and an orthostatic challenge, such as a tilt table or standing up. And the reality is the way that people breathe can for sure change this. And we see this all the time, and you've probably experienced it before, where if you start breathing fast and heavy, then you're likely to kind of throw yourself into a little panic. But there are other times when that's not the thing that's going on. We can see the other variables start to change. We can see cerebral blood flow drop. We can see heart rates go up. We can see this happen before we start seeing any changes in the breathing, or the breathing may not be affected at all. So what do you do in these cases? Like, how do you figure that out? And that's actually where the real insight comes, is when we see cases where blood pressure may stay the same, symptoms may present, respiration is the same, but we're still seeing this hypocapnia. We're still seeing this drop in end tidal carbon dioxide. And that's kind of what we want to talk about tonight. So, any questions thus far? How we doing, Dr. Kipros? Am I cogent? Still making sense?
We're doing great.
All right, cool. I see that there's some people dropping some questions in the chat that aren't specific to the topic, but they're kind of like ancillary. So we'll come back to those. So I do see you. But I want to tell this story first, okay? So imagine you are on a tilt table, and this happens like most of the time. So you're on a tilt table, you come up, we see heart rate goes up, blood pressure stays relatively the same, but we may see a drop in cerebral blood flow, and we may see a drop in end tidal carbon dioxide, even though breathing doesn't really change. And so when we look at that, we've got to start to figure out, why is that happening? Because if that CO2 level starts to drop, it's going to further make it more difficult to push that blood up into your brain, because we're going to get constriction in those vessels, and it makes it even harder. So here's the deal. The same way we get hypoperfusion in the brain, we also want to think about that in terms of hypoperfusion in the lung. Lungs, plural, you get two of them. They both work the same. Okay, so if you kind of stop for a second and go, oh, I can see how that's possible. Remember that, let me see if I can pull it. I don't have a good way to draw this right now. So you got two sides of your heart. You got a left side and a right side. The left side is the side that pumps all the blood into your body. Big job. Before it does that, though, it's got to get fueled up in the lungs. It's got to get all the oxygen out of the lungs so that it can push it out to your body. So, old blood that comes from your body is actually going to go into the right side of your heart and get pumped into the lungs. And then it gets kind of pumped back to the left side of your heart, back out to the body. Simple way to think about it. So it's like a little train. It goes into the heart, into the lungs, back to the heart, out to the body. Everybody knows about well, not everybody. It is a common thing to talk about with venous pooling. Okay, so people will commonly say, like, the venous pooling is my problem. I can see my purple legs. I do not like it. I can feel the heaviness. I can feel that. What we don't account for sometimes is that when every human stands up, we all displace blood from our upper body, our thorax and up, into our lower body. Splanchnic arteries, like in your gut and then in your legs. We all do that. So, and like quite a bit, 500 to 800 milliliters for our Canadian friends. For the Americans, or they're like, I don't know what that means. I get it. Me either. Just kidding. But it's like a decent bit. It's like 10% ish of your blood flow, maybe a little more. 10 to what is that? 10 to 16% of your blood flow. Okay, so all of us have a pooling effect. So how do we make up for that? Because you're not escaping gravity. If there's a little bit of tension on that for all of us, the way we solve that problem is we create some more constriction in the blood vessels. This is what we talk about a lot. And that constriction in the blood vessels allows us to compensate for that pooling. So we all get a little bit, but we have the ability to tighten up the vessels a little, and that maintains the blood pressure and keeps that system rocking and rolling. Fair enough? Okay. So if that is the case, what we are looking at is kind of, we're able to measure the difference in people between being able to compensate for that shift in blood pressure versus not being able to compensate for it, or the venous pooling, right? So can we compensate for that or not? In the same way that we can see that affect the output going to the brain, we can see that if we're not returning as much of that blood to the heart because we're not compensating effectively, then we're going to find that it's also going to slow down some of the perfusion into the lung. And when that happens, we're going to get what's called alveolar dead space. And what that means is we don't have enough blood to fill out all those little capillaries of the lungs to be able to create exchange. So even though you're breathing in the same amount of oxygen, breathing out the same amount of carbon dioxide, the exchange that's happening in the lungs is going to be a little bit slower because the blood's not coming in as fast. So it's not able to, the blood that's returning over to the left side of the heart to be pumped out isn't able to like get that handoff. So it's like the air is coming in, but as it's circulating through all those capillaries, there's not as much perfusion into the capillaries. So they're not going to be able to carry quite as much, and we get a dead space. So it's actually going to look like, because that exchange is happening slower, that we're going to get a lower amount of carbon dioxide relative to what may be circulating in the blood supply. So it's actually an artifact of the equipment, because we're using this cannula to measure the blood flow. It's measuring the ventilation more so than the actual arterial CO2, which is really important. But so then you go like, oh, well, you're just like measuring the wrong thing, right? You got to measure the blood, and that's reasonable. But also, in a normal system, you shouldn't have that happen. There shouldn't be enough dead space created to where we start to see that ratio change. So by the mere fact that it does change, it tells us that not only are we likely poorly perfusing the brain, we're also likely poorly perfusing the lungs. And that helps us understand a little bit better that even though we're in the environment where the arterial pressure is high enough, we're not able to coordinate blood flow well enough to circulate it back to the heart. So what do? We rely on outputs of the sympathetic nervous system to the blood vessels, not the entire sympathetic nervous system, specifically the part that constricts the blood vessels, and we have to crank it up. What does that do? It increases the amount of norepinephrine that's going to be discharged at that neuron level, and we're going to see an increase in the heart rate to try to compensate for that speed as well. This is why it looks, this is where we start to blur these lines between, like, obviously if we're cranking out the heart rate more and we're cranking out vasoconstriction more, then if you sample what that looks like in the system, you're going to see more evidence of sympathetic flows, right? Because it's being worked, it's being used, it's having to mobilize and create more energy to do these things. So then you could look at that and say like, oh, the sympathetic system's working too hard, must be the problem. But that would be like saying there's always an ambulance at a car accident, must be the ambulance is causing the car accident. It's a secondary effect. So this is where that hyperpots or hyperadrenergic pots starts to take hold. And then at the same time, we look at that as like, oh, but that's also, you could look at it through a different way, and it would look like, well, that's maybe hypovolemic pots because we're not getting the return, right? And then if you looked at it through a different entrance, you could say like, oh, that's low flow pots because we're not getting perfusion to our brain and to our lungs and to the rest of the system. So you realize that you're just looking at this thing through different angles rather than understanding the mechanism underneath. So we talked about today this translation where people were having people do exercise, and exercise is different for everyone, but in this particular case, one of the things we're focusing on is how do we start to maintain CO2 levels resting, even just laying down, and then transfer that toward normal values when we're upright. So it's a process because you have to be able to work out this whole system in a way that it can tolerate. You can't overload it or it'll fail. But if you can back it down and say, let's grade it up slowly, then you can see the body respond to it. And that is why I'm so thankful for people like this patient we're talking about, who I think is here, um, for them being motivated to be consistent. Because sometimes, like this conversation that we're having right now, even though we do have it in the clinic, it's hard to hold all this stuff in your head. It's hard for other doctors to hold it in their head. So it's hard to hold it in your head. So when you are doing your, your home exercise, it, you may not have the command to be like, I'm doing this precisely because I'm trying to get better perfusion into my lungs and into my brain. And this is exactly how it's going to happen. It's going to be amazing. That is not the feeling. The feeling is, oh, this is hard. I got to do it again tomorrow. Bah, it's hard, right? It is hard. It's a workout. It's hard. So hopefully that gives a little bit of an insight into what we're thinking about with hypocapnia. So when we show those charts, and I don't have one for you tonight, but when we show the charts and we see them dropping, what is happening in my brain is I'm thinking this perfusion isn't just being lost in the brain. We're also losing some of this effect into the lung. We're not being able to coordinate blood flow effectively. How do we get better at that? And then we're going to try to hunt for that answer. So, Dr. Kibros, I have you sitting here. I'm sorry I'm not letting you speak because I'm a ball hog. What do you think?
Yeah, I think it's a great conversation to have, in a way of looking at it is like, how does the system actually work in a whole instead of parsing out little pieces. And I think that's a lot of the time what we're trying to look at when people come into the clinic, is they might have an idea of what's going on in like individual systems at a time, but we're trying to look at how is this all functioning and how does this make sense as a whole, and giving them strategies to get to that underlying piece that's going to affect the whole thing.
Yeah, and it's hard. It's not like that's not easy. The way our brain is really good at being like, if this, then that. If this, then that. So we're really good at thinking in a line. But unfortunately, in the infinite beauty of humanism, we aren't built in a straight line. We're built in this big, beautiful mesh of things that are all happening at the same time. It's like showing off a little bit. Like, look at all these things we can do at the same time. So hopefully this is a little bit helpful in starting a conversation about hypocapnia. Okay. And hopefully maybe you watch it again, maybe you don't, maybe you're like, this is crazy, we're not going to do this. But I want to continue having this conversation because I do think it affects so many people, and it has such a major, 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 major impact on cerebral perfusion. So, hot tip for everyone out there, for every unit that you're going down in CO2 levels, we measure them in millimeters of mercury. So for every one you go down, so like every one you drop under, you're losing about 3% ish of perfusion in the brain. So, once we start losing 5, 10, 15 millimeters of mercury, like it is cranking low. I also want to point out, though, that this is not the only way that we get to hypoperfusion. There are also people that have profound perfusion issues that do great with their CO2 levels. That's not where the problem is, right? I think I saw somebody, I think it was Dennis, said, related it to posture and obstruction. And I think there was a comment earlier about looking at internal jugular vein compression, where in these cases, the return maybe isn't the problem. It's the getting it up there that's the problem, right? So we can't solve them the same way, but this helps us to be able to parse them out. And that is like what I get super excited about. To me, one of my favorite things is to be able to tease apart where the problems are and say, like, I know you feel like it's this thing. We're going to focus on this one problem. We're going to fix it, even though we think it's this big one, but we're going to fix this thing here. And uh, to me, that's amazing because that's the difference between like winning and losing. So if we treat everybody the same and everybody gets the same protocol, there's going to be a large percentage of people that lose. We're going to get some right, but a lot of are going to lose. But if you can design it and say, like, I don't care about a protocol, we're just going to figure out what's wrong with you, and then we're going to be creative in trying to solve it, then obviously each person's outcome has a higher probability of winning. So should we take some questions, Dr. Kipros?
Let's do it.
Can you see them on your end?
Yes.
On the chat at the bottom of that little thing. So I see a lot of them. I might not get to all of them because I wanted to. So what I noticed was that I would see a big pile up of questions and then feel like I got to burn through these. And then I realized it was like answering them quick rather than like in a good way. So let's try to answer them in a good way. I'm gonna bring this one up from Megan because I remember her talking about this. The big CO2 suit that you put on and try to perfuse it in. And then I've actually, so we're testing some of these at home, looking at CO2 rebreathers and isocapnic breathers. My good friend, Dr. Perry Maynard, and I have been kind of cycling through some of these things and trying to figure out how we can best use them. But we test them before we bring them into a clinical setting. But yeah, so some of these tools like this one Megan's talking about, like a CO2 inhaler, low dose CO2 breathing machine. I don't use the ones that actually low dose it in. I kind of like the ones that are more of the isocapnic systems, like the balloon systems. And you're just doing a rebreather. But something like this may work, but it just depends on what the underlying is for sure. So yeah, good feedback. And I know you tried that super suit filled with CO2 as well. And those are a little wild, but fun stuff. So then I think this is a good question right here. So Matheson comes in hot with questions quite a bit. So be ready. Fastballs every time. Can shallow breathing ever be a temporary good coping mechanism? I feel like it makes me able to tense my chest in a way that makes my head pressure feel more stable. Normal breathing and relaxing. Normal breathing in my chest makes me feel lightheaded. So my sense of that would be like where your kind of set point is in terms of where your body's trying to keep a normalized basis. In other words, if normal breathing and relaxing your chest makes you feel lightheaded, then a couple things to consider would be things like obstruction, things like Dennis was talking about earlier, where just having that change in the breathing mechanism may make you feel better. Dr. Kipros, what do we notice? I mean, we see all the time where people will just do that
Hunch.
and they'll just fold over because it's easier to breathe that way. Right, but it's not maybe like the long term. So I think that might be kind of what you're noticing and just kind of breathing really shallow. And then sometimes as people breathe bigger, it's also going to compress the heart. So if there's any irritation in the pericardium, if there's any pleural irritation, which is like irritation around your lungs, or you're getting compression in the system and you expand and create more volume, you're more likely to kind of like squish the thing that's already squished. So some people will notice that they choose or they prefer to breathe that way because it's not creating so much obstruction as well. And so like here's where you bust out the old stethoscope and you're listening for the bruits or the interruptions in blood flow around the system to try to understand how those are related. So great question. Another fastball strike. Appreciate it. Anything to add there, Dr. Kipros?
No, I think that one's always interesting. I think most people, when they think of hyperventilation, are just think about the really fast breathing. And then sometimes we have to talk to people that the really deep breathing that can sometimes people want to go into that almost as a method of calming themselves down, or they've used it as a technique in the past. That can also be a form of hyperventilation that decreases that CO2 as well. So when this person talks about shallow breathing, it makes me think of like shallower than super deep, because maybe super deep is what's causing the issue. And if they just start to do more of like a sipping of the air, which is something we'll say to people, like just sip the air, it should be neutral, that brings them more to a baseline there. So that would be something interesting to look at too.
Yeah. Yeah, and I want to make note that like people that have poor CO2 tolerance, like it is not comfortable to sip the air. Like it feels like you are gonna die a little bit. Like you're breathing, like you are choking out. And so, but what we're trying to do in those cases is your body gets you. And Nicholas, I'm reading down on some of these, but so as you start getting the sensation that you're running out of air, most people don't have like a very pleasant response to that. That is not a Zen state of being, right? So when you feel like you're running out of air, it induces all of the wonderful anxieties that we were meant to have. But if we're doing that at way too early of a rate, so we're too sensitive to that, then that's where we start to spike into these like more anxiety-based patterns or anxiety-based physiology really early in the game. And we actually have to like work people through that. So it's like spend a little time there and then also talk your body off the ledge a little bit so it doesn't freak out and like get more used to it. So we say it in a way that it's just like, yeah, we just do this thing. But also like it's not the easiest thing in the world, and I don't want to undersell it in that way. But what I love is we can see a lot of people that are super tough and very motivated. So they do it, they rock it, and we're very lucky to be able to work with people like that. Cool. I think this one's interesting here with Bella from Down Under. That makes so much sense. Latest CT actually showed partial lower left lung collapse. Had managed to improve with breathing exercises. So when we see these, also thinking about like the quality of the diaphragm excursion, how well that's working and how well it's innervated can be a problem at times. And then also, obviously, if we poke holes in people, that's not so great for maintaining lung filling. But that is actually where people started to figure out this relationship between like that alveolar dead space. That's kind of that comes out of the collapsed lung literature, where you're looking at the amount they're breathing is not correlated to what's getting perfused. So that's a really good insight. Nicholas. Oh, I wonder if we're back in school time. As you know, ETCO2 is always low, 30, 31. A little bit low, yep. Even lying down, slow breathing, lower standing. I've been doing cardio. I'm monitoring the capnograph, but can never quite get it above 30. So we work on finding just a little bit more output from the metabolism, the musculogenic side. But yeah, let's step back and talk about that. Your next question is actually on point because this is reflect a calibration or set point issue. Can you recalibrate it by keeping it in range? Yeah, that actually works really well. But another thing to consider is also we want to make sure that your unit is calibrated correctly too. So we've had instances where people are just cranking away and they're like, yeah, this is I'm at peak. And then we get the unit measured and we get it calibrated and it's calibrated low. So keep that in mind as well, as you may be doing better than you think. But we can circle back and we can talk about that offline too, and see what we need to do to address that for sure. But good to see you. Hope life is good. Um, okay, so Elisa, we're getting into like some blood draw questions here. Um, where did they start? Where did I lose you? So looking at the venous blood gases. So venous blood gases are going to be slightly different than arterial blood gases, as you know, which is why it's a little bit tougher. So like when they do the draw in the hospital, it's way obviously easier. But that kind of is how people end up in the capnography space. There are two main kinds of capnography. Um, they call them mainstream and side streams. We use a side stream, which is basically sampling the air coming out of your nose and your mouth at the same time, and then it runs it through a machine. There's a little delay because it's got to run through the machine, and then it spits out a number. And then there's a different one that uses a little bit more of a robust measuring system, but it actually uses a little laser that's sampling through the laser, kind of like a pulse ox does in a way. And then you get a little bit more of a sharp response to that. There's just a little bit different technologies. We opted for the side stream because we're also putting other stuff on your head, and we just ran out of head to put stuff on. You couldn't fit it all on without making like a custom mask. And Dr. Kipros wouldn't fire up her 3D printer for us on that, so we're still waiting. But yeah. So anyway, so that's just like a little technical standpoint there. Um, dun, 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 dun. And that we talked about Dennis. Bella, what is that best exercise? So there isn't only one. That's what's great. We're just going to pick the thing that allows you to be able to create output that doesn't overstimulate your system. It's like especially in our MECFS crowd, where we're really trying to dance the dance with post-exertional malaise. So we're trying to do the thing where it's like we can sneak the exercise in without overstimulating people, but then be able to drive enough activity and enough. So basically, to be able to produce energy to do stuff, whether that's thinking or using your muscles, we have to create ATP. And in the process of creating ATP, the byproduct is we get some CO2 out of the deal, and it's coming into the vessels. So we use anything that's just kind of large muscle stimulus in a non-provocative position. So it could be like swimming with a kickboard. It could be, laying down and doing some sort of weights or cardio. We like to use an exercise bike laying down as a starting place, and then we use a tilt strategy to get people back up bit by bit. We like that one just because it's readily available and it's probably the lowest level of difficulty. We use the Kaiser M3 bike, which is obviously the best bike, of course. Family business. It's not actually, but it uses a magnet system that allows you, if you turn it down low enough, once you get going, it'll almost like pull your legs through in a way, which can be useful just to kind of to get people moving, because we're starting sometimes at a really low rate. So there are lots of ways to do it. I like the pool if you have access as well, because you can create hydrostatic pressure around the body, and be able to kind of stabilize flow that way, which is pretty sweet. But lots of ways to do it. Just kind of depends on how you want to think about each person. Anything to add, Dr. Kipros? What do you think?
No, I agree. I think it just depends on the person and the best position for them that's going to allow them to be successful and actually, like, first do it in a position, like you said, that is allowing them to produce the energy that's needed, and then also maybe something that they don't mind doing day to day, because you're much more likely to do it if it's slightly more enjoyable.
Yeah, that and especially when people go home, right?
Yeah.
that we got something that people, there's a low friction to, so it's not hard to do. So if it's winter time and you're like, you got to go outside, you got to be able, you got to shovel the snow off the walk, and then you got to, no, you got to have something that is like, I can fall out of bed and into my exercise. And that's kind of what we're aiming for. So we just kind of wipe everything off the table and try to think about how to do it for that person. Eddie wants to know, I wonder which Eddie this is. I wonder if this is an Eddie that we know. What doctor can diagnose hypocapnia? Great question. Someone that has a lab that measures these things. So that's a good question, to be honest. People that could do it would be anybody with a cardiopulmonary lab. My hope is to see more tilt labs using these techniques. It's been slow going, but we're trying to talk them into it. And then so like in cardiology departments or neurology departments. But that is a great question. You're probably looking at this stage for somebody that's specialized in a way that's not the easiest to find, unfortunately, but that's what we're trying to fix here. So, and then Eileen has a nice compliment. It's hard to hold on to all the info, but your staff is so great at questions through email after we leave. They're amazing. They work really hard at it. It's a lot of time. I don't know if you know this, but there are a lot of you out there, and we like to try to answer the questions. So we really appreciate you saying that, because it's a thing that we put a lot of work into. Megan, what if you're experiencing hypocapnia and very symptomatic, and you use something like CO2 inhaler, but it doesn't relieve the severity? Is it still a true CO2 issue? So this is good. I think you're throwing me a softball here because you want me to reiterate a point. So I appreciate that. Let's clip this and put it on the good brain. So using the CO2 inhaler may be an indicator that helps us understand the actual perfusion of the lung. So if we're still having issues with cardiac output, being able to generate perfusion in the lungs, by supplementing CO2, that doesn't help us actually exchange more of it at the capillary level. So we talk about so let's talk about lung anatomy. Super brief, I promise you'll love it. Okay, so your stuff promise. So your lung kind of, when you look at a lung, I don't know how many people have seen one. The tissue's kind of like a little sponge, and it's full of blood vessels. And it's a sponge because it has all these little nooks and crannies. And the nooks and crannies allow it to trap the gases, the oxygen. And that allows it to sit in those little nooks and crannies like a little sponge. And then so it can soak into the capillaries. It can diffuse into the blood vessels. And then that way, when you breathe, it kind of creates this pressure and it kind of pushes it out. And that's what happens. But it wants to get tucked into all these little nooks and crannies so there's enough time to exchange it with the blood supply. But if we get the oxygen there, it's like the train station is full, right? All of the passengers are there. But if the train doesn't come, we cannot get them on the train. So if the blood is not coming fast enough or perfusing enough, then we can't get it in as well. And then we're going to see that. So even though it may, it's still circulating, it may look like we have oxygen, it may not be at the same rate. And that's where we see that slippage between the EtCO2 and the PaCO2. And it looks like that CO2 level is dropped more. So that's kind of part of it. Is in some respects, the CO2 level may not be adequate, but it also, when we measure it in the blood, it may be adequate. But what we're actually looking at is the change in the instrumentation between the capnograph and the arterial draw. And I'm realizing as I'm saying this, I made it more complicated. So let me try that backwards again. Sorry, sometimes when I'm trying to make it easier, I don't know what I'm going to say until it comes out, and that one I'd like another swing at. Yeah, so if you're isolating the CO2, if you're saying I'm just going to keep like enough CO2 in there, It doesn't necessarily mean like the CO2 we're measuring is a byproduct of the system. So breathing more in may not be that useful because what we're seeing is the evidence that the exchange isn't happening well. So by supplementing more in, that's not necessarily solving the problem because the problem is downstream. So putting more into the situation doesn't really help. We need it to exchange at the lung, and that's where the problem is. So hopefully that makes it a little more clear. I need my engineer translator. What do you think? What do you think, Dr. Kibros? You want to clean that up for me at all?
No, I think you did okay. I think it's like we have to look at what phase in the system is the problem happening. And if we're trying to address it here, but the problem is here, we're just not hitting it at the right point.
Yeah, you're kind of hitting it after it's already happened. You're basically supplementing the thing that already happened. So it's already you're kind of like you're too late. You're yeah, you're trying to solve a problem down the line, which isn't bad. And for some people there is application to breathing in more CO2 because of just the exchange of how they're breathing. But in this particular case with what we're talking about, I think that plays out. So thank you for cleaning that up. Josh, good to see you. Hope school's good. Cerebral perfusion is more steady, but hypocapnia is more of a problem. How do you fix that? Um, well, again, so this kind of comes down to, and maybe we clean this up down the line, but if hypocapnia is the problem and it's purely based on hypocapnia, we actually have a couple different reference points here. So we've got the exchange that has to occur at the lungs. We've got the production that has to occur at the mitochondria. We've got the transport through the vessel. And we've got vasoreactivity that's happening in the brain. So all of these are different potential failure points. So when we talk about hypocapnia being the problem, it could be at any one of those points throughout the mix. But when we look at specifically that tension change in a tilt test, part of that is understanding like how that's related to the perfusion is important to help kind of figure out how they are matched. So like you might experience, like let's say you see someone has a low perfusion that starts to improve, but the hypocapnia still remains. We may be looking at still having a sluggishness in being able to create the venous return effectively. And as a consequence, you're able to compensate it well with the arterial system, but it's not compensating quite well enough yet to where it's able to fully compensate the lungs. So we're not able to fully we're not back to full 100% at venous return into the right side of the heart to be able to press on. So it can compensate through the arterial system, and it's still kind of gaining that strength through the venous system is a way to think about it. Okay. Would breathing retraining programs like Butico help? Yes, the Butico breather is pretty cool. All those things are useful. They may not hit it directly. So I would say specific person to person. I don't know. Some people it'll help, some people it won't. But I would say as a general tool, they are pretty cool. And you'll know reasonably well. You're going to at least be doing something that's generally good for you. For most people, it's not going to be a net negative. But it just may not be the solution to your problem. So that's like what I would go in with an understanding of, but I wouldn't be against trying it because I don't think that the downside is pretty negligible. You'll know if you like it, and it's a pretty cool tool. Interesting story. We actually looked at these and trying to get the U.S. license to be able to produce them years ago, which was a wild experience. Didn't get them, short story, but we spent some interesting time trying to communicate with some Russian people before we had good AI or translating systems, and that was an interesting game. Anyway, Rob, it's late. You're supposed to be in bed. I know exercises are different for everyone. There's a good caveat. Share examples that you might prescribe to patients who have been diligent in doing their home exercises. That again, so you may be in different categories. So Dr. Kibros, we might be in Might be a component of vestibular rehab that we need, or oculomotor rehab, or we may be using some proprioceptive rehab or manipulative therapy. Like, so those are all like categories. We might be doing peripheral stim. We might be doing dual tasking events. But if we're just talking about conditioning based exercise, more like traditional physical exercise, that's kind of what Dr. Kipros was talking about with using the supine or laying down cycling, using the pool, doing some swimming laps, anything where we're taking the gravity burden out of the system, we like to start there. So it's kind of like, let's start just seeing if we can get your body to do some exercise, and let's take away all the challenges we can think of, and let's just start at the basics with movement. And we can always add resistance. We can always add gravity. We can always make it more complicated, but just start from the basic, and then build from there. And if you use that as your structure, you can, if you're savvy in the world of exercise, then you can build it off anything from there. We often start with just simple cycling because it's an easy way to move your legs. We can control for neck posture. We can control for symmetry. We can put people in a Neuro 20 suit so that we can control for the stimulus going into the body. So it just allows us to pull down a lot of the variability and to be able to control it more. So that tends to be where we start. Fair enough? How many people we have using Neuro 20s this week?
2 or 3.
2 or 3? It could be it's a super tool, especially when we have people that don't have a full solid awareness of their body. So I like the coupling of being able to start to link back the passive stimulus of the muscle back to the control system. And I think that's a wonderful tool. So, and all of my doc friends out there, I'd encourage you to consider it. You can give us a call. We can kind of show you how we move it if you want. Okay. Dennis. Dennis, I think we got a topic you like tonight. I've read that chronic hyperventilation allows your brain and body's sensitivity to CO2 levels change. And if you try to breathe normally, it can worsen the symptoms. You need to retrain. So yeah, this is out of the work from, oh man, I'm blanking. The Irish fellow. Do you remember Patrick? Sorry. Should have that. And then, so he did that work. This kind of goes with the Buteyko stuff. This is where like the tape in your mouth comes from, doing the nasal breathing. Yeah. Brian, there's another guy. Oh man, my name recognition's not on tonight. Going deep in the memory box, but we got a conversation with Brian. Also, can't think of his last name at the moment. And then had a conversation with him and Andrew Heuermann about this as well, and who most of you probably know, wonderful guy, by the way. And yeah, talking about nasal breathing as being a huge structural addition, but that's what Dennis is talking about here, where trying to reduce that sensitivity and slow down the breathing is helpful. And I believe there's a derivative book, I think it's Breathe, that they kind of cycle in some inputs from divers, deep divers, and how they control their breathing. And it's a good read. And trying to override that manually, like the retraining side, can be really good. What we found is we used to do way more of that. But we found that if the reflexes underneath it were like misreading, were not integrating appropriately, then people had a super hard time training through it and it became long and arduous. But if we were able to do things that helped with the reflexive side under it first and then retrain them, then the results were a lot faster and they were less like work. So we've kind of shifted to that, but we still use the training. We pioneered using prone nasal breathing as a strategy that just puts people in some different positioning. So if we lay them on their stomach, we lay them on their stomach with a pillow under their chest so that we actually change the trajectory of the lumbar curve, which allows the diaphragm to get more mechanical advantage so that it's able to open the lungs more efficiently. And this talks to that alveolar component. And then laying prone allows that blood flow to be able to pool toward the lungs so that we can maximize perfusion. And then by doing that, we can have people actually put their head in a better position. So we have a lot of neck issue people. And then we can have them breathe slowly through their nose and practice that. And we use that a good bit. Um, it's not been validated, so we haven't written a paper on it, but it's a technique that we use that I've been really happy with. So if anybody would like to try it out, that is one thing that we do. So you're basically combining postural elements with some gravity to help that breathing mechanism become a little more normalized in the process. So breathing, it's pretty cool. Am I missing anything, Dr. Kipros?
No, but thanks, Carol. Patrick McCowan.
Yeah. Did you? Yeah, there we go. He's
Carol.
actually
Carol put it
he's
in
done
there.
a whole
Thanks,
bunch
Carol.
of stuff online. Wonderful videos. He's just been a super share kind of guy, teaching people how to breathe right. He had his own breathing problem as a kid, it's all stuffed up, taught himself how to breathe through that, and very cool. Getting an inflammation out of his sinuses. Love it. Yes, thank you for that. Cheryl, speak more about deep breathing. I used to breathe very shallowly and it really increased my lung capacity. How can it be dangerous and how does one determine the proper amount? Um, I mean, you're not going to blow up your lungs by breathing. So the bigger part's not problematic unless it starts to make you feel dizzy or lightheaded or symptomatic in general. Um, this is where, like Dr. Kibros talking about, we often ask people if it makes sense in the conversation. We'll talk about like, do you meditate? Because meditation usually comes with some sort of prescribed breathing. And in that prescribed breathing, you're usually asking people to breathe at a bigger, slower rate than they typically would on their own. And is a really good time to identify. So a lot of people will self-identify and say, I don't feel good when I meditate. I get lightheaded, I get dizzy, I don't like it. And so those can be just easy indicators in a conversation about how that's going. And we kind of dive from there. Okay. All right, what do you think? Should we take a couple more? Now you got a little one over there. Do you need to tend to? Do you need to put anybody to bed?
It's pretty quiet in my house, so I'm thinking Dad got
I'm
him to
thinking
sleep.
dad for the win. He's a good
Uh,
dad. He's a good dad. Shout out to dad. I always feel weird naming people because I don't know like what the protocol is there.
I feel like if
Anyway.
it was not going well, we would have had an appearance by now. So,
Yeah, you'd be rocking.
yeah, I
Well,
think so.
if at any point you've got to go, we understand. We appreciate you being here. Oh man, I scrolled and now I'm just lost in the chat. There were more questions than I thought based on the size of the slider down there. Where are we? Okay, got it. Oh yeah, Carol, this is a good question. Dr. Kipros, normal CO2.
Normal CO2 is between 35 and 45 millimeters of mercury.
Yep. And then we actually don't start getting real concerned about it until we get. So Nicholas has mentioned 30 or 31. Like we're still in survivorship there. It's when we start getting into the 20s, especially into the mid low 20s, teens, that these are like the problem children in the room. But right around that 30 mark, you can make that work. So like if you look at Peter Novak's paper with hypocapnia, they set their mark right at 30, under 30 as being the hypocapnia mark. So we kind of want to live close to that. Cool. So Nicholas, maybe that's a little reassurance for you too. What do we got here? Linda Ward asks, have had an uptick in symptoms, tingling in hands, feet, legs, lightheadedness, dizziness, vertigo, occipital/neck pain. Also notice I'm piercing my lips when I'm breathing, like with a straw. Um, it's an interesting observation. It can be meaningful, but I don't want to overgeneralize to what it might mean. Um, in this case, but trying to understand where that uptick's coming from is probably useful. If you feel like you're kind of breathing weird, seeing if slowing down and just trying to slow your breathing down, some of the tips we talked about earlier, might be a little self-study that you could do to see if it modifies the way you feel, and that might be a little thing to write in the notepad and either work on yourself or take to your team. Cool. Johnny, welcome back. Curious, can any chiropractic neurologist help with OI or POTS? Um, Possibly. So, chiropractic neurologist, super good training in terms of thinking about brain and neurology, and just like anything else, some people are specialized in different things than others. So it's kind of to the comfort level of the practitioner, their experience, what they know, what they're good at. Kind of just like anything else, some people are good at some things, not others. So I would say, and it's a general statement, our colleagues are wonderful. Um, but I can't make a promise that you're going to land at one that is like that this is their sweet spot because there's a lot of variety. Okay. So Nicholas' question, does low baseline CO2 just mean that mitochondria aren't kicking out enough, or it's the brain telling us the right amount? Could be either one. So it could be that we're having problems with vasoreactivity, like we're just not understanding the signal right, or it could be that we're not kicking out enough metabolism per unit, and we're seeing that low. Now, you'd need, I mean, remember this is systemic, this is a whole body. So on the mitochondrial side, that's the thing to consider. I would be more interested in kind of do we have evidence that other systems aren't being able to coordinate in the same fashion, and then ruling that out first because um, like mitochondrial systems aren't. Let's see what I think about this. Like you have mitochondrial disease, you get a mitochondrial impairment, you're going to over time, we all do. But to see it like, as a systemic manifestation like that, like might look a little bit different, if that makes sense. SD was in the mountains last weekend, got fluids and that helped, but apparently had altitude sickness issues. Very hard because I don't always remember some of the events. It makes me feel crazy. Yeah, altitude can be a thing for a lot of people. Like I was mentioning, we got a colleague, Perry. He's out in Colorado, and so like when we consult on patients back and forth, that's always kind of part of our conversation is how people are managing that ascent and descent. Because it can be trickier for certain people in the mountains. Been home for a few days, definitely felt rough. Basically, what's happening to folks at sea level when they're struggling at this. Is this basically what's happening to folks at sea level when they're struggling with this and their CO2? In some respects, it's a good way, like subjectively, the way it feels is like probably a good way to internalize that. Whether it's the exact mechanism may vary, but on the sensation side, I think that's a good way to think about it. So yeah, Eddie's describing having empty nose syndrome leading to subconscious hyperventilation. After developing this dysautonomia turns to MCFS. And so like turning into is just a function of like becoming more profound where you're getting more of the difficulty in the recovery side. So when I like a shorthand for me when I'm thinking about MECFS is I'm thinking about it in terms of not like the recovery system is profoundly impaired. So when you're doing a thing, the system that should come in and clean up is on strike and they are not doing it very well. So the cleanup crew takes way too long and doesn't do a very good job. So that whole active recovery model um, is a place to explore, and so that's a shorthand that I use in my brain. Let's see. Why does the tilt test read hypocapnia and POTS, but CO2 is normal? I'm symptomatic. Mm, so Eileen, if it reads hypocapnic, but then the C that's saying like the CO2 is not normal. So do you mean the CO2? So does it normal to start with and it changes on orthostasis, or is normal afterwards? That would be the consideration there. I might need to clean that one up. Good question here from Dennis. What about kidneys? People with POTS can have issues with aldosterone, renin, and it causes blood volume or sodium issues. Doesn't that also affect CO2? It can for sure. But that is interesting because a lot of those are not measured problems. They're kind of assumed in a lot of people. So if that's true, then we kind of have primary kidney disease. And we want to look at glomerular filtration rates. We want to go to the nephrologist. We want to take a look at that. But sometimes it's assumed that that is the problem, and we put people on the medications for that. And there's a lot of literature there, so I'm sure you can get super deep in that, as I have. But yeah, this RAAS, the renin angiotensin aldosterone system, helps to maintain blood volume. And so if we are having problems there, this is where people think about cardiac problems using ACE inhibitors and stuff like that. That is in this range, but it can be the problem. But again, here we're starting to, get into more of the nuance of nephrology, where we may have genetic conditions, problems with, kidney disease, kind of in that territory. Otherwise, when we think about POTS, these are kind of assumed errors, and we're using medical intervention usually to try to manipulate these systems as a way to increase blood volume. Not necessarily because they're faulty, you're actually assuming they're working well, so you can kind of pull the lever of them to override the system. Okay. Josh, love that school's going well. Just debating your face off over there, I'm sure. Okay, I'm gonna do a couple more. What do you think? Anything you wanna stick in there for us, Doc? I appreciate you being here.
Yeah, I might go check on the kitty and the husband and see what's going on up there. But I love being on and happy to jump on here anytime.
Awesome. Cool. So I'm gonna do this one from Cameron. Let's see what she has to say. If venous pooling is driving the hypocapnia, is exercise improving the venous pooling component, or is it exposing the chemoreceptors to what normal CO2 environment should be? Excellent question. So remember, everybody has venous pooling, all of us. So the question is more, how's our body responding to the pooling? Because it's like it's like sitting into a hammock. It just kind of settles down to the lower portions. But then in a healthy person, we have the ability to just manage that. And so if we're seeing that, can we get extra pooling? For sure. If we've got laxity in the vascular system, it's just not responsive. But you could also consider that as like we're not able to coordinate it well enough to mobilizing it going. So I think you're hitting square in the middle of both of these, where you're actually looking at the ability to accurately mobilize that blood supply to be able to recognize that it's altered and to be able to create the environment that would normalize it. So great question. Love that one. Appreciate you. Nicholas, I'm going to take this one. This is going to be my last one. I remember you breaking down hypocapnia as either autoregulatory issue or vasoreactivity issue. These are the only causes. Be cool to break this down. I'll pretend to know what they mean. So hypoperfusion. So cerebral hypoperfusion, not getting enough blood flow to the brain. These can be things where two of the primary problems that can exist once you enter the skull and you're in the vasculature. So like once we've isolated it down to there, we're kind of looking at a couple different things. We've got autoregulation, which is just the reflex. It's the stretch reflex against the artery. So if too much blood's getting in, it slows the amount of flow down. If not enough is getting in, it opens up and says, give me all you got. That's autoregulation in a sentence. Vasoreactivity is that same blood vessel's reactiveness to CO2. So if the CO2 levels are low, does it react by creating constriction? If the CO2 levels are high, does it react by creating dilation? Sometimes that fails, especially with endothelial dysfunction. So that's what I think we were talking about. We also have problems with neurovascular coupling. These tend to happen more when we get glial activation or problems with the coupling between the end foot of the neuron to, the end foot of the glial cell to the neuron to the capillary. Basically, if you get your head knocked, rattled, infected, then we can see where the neurons have to heal. And by healing, it means we have to be able to pull in some inflammation, which means we have to decouple the neurovascular system, and it may or may not turn back on. So there we go. Looks like Dr. Kipros bid adieu for the evening, whether on purpose or not, it's okay. But we really appreciate having her on. I appreciate all you guys here. I know I wasn't able to get to them all tonight, but man, you guys ask great questions and I love it. Hopefully, this is the first of many conversations about CO2 levels, but I think it's a good place to start. I think we upped our knowledge base and I like doing these. So I like answering the questions. To give you a sense of it, so I will kind of, once the questions start to kind of roll over and we're doing similar ones over again, then those are signals to me that I want to, like, we got to give you more stuff so we can handle more. And so we will keep doing that. I've got 1,000 slides worth of information that we can go through. So there's no shortage, but I'm just trying to do it in a way where it can be useful. So I hope it's useful for you guys. What I would love is to see you next week. And if you don't mind, it can be helpful. We've got some feedback that is really helpful if people just share like a little something that's great in their life in the chat. Doesn't have to be anything profound, just a little something that's great. And all of those littles add up and we can pull, even if we just help one person out of a bad day, we're winning. So if you guys consider that and we check in on the chat next week, just throw us something that is going well. That would mean a lot to me and it would mean a lot to some of the other people that are here that you maybe don't see in the chat, but are here and really feeding off your energy. So with that, I'm going to say goodnight and I hope